Developmental dysplasia of the hip represents one of the most critical conditions you'll screen for in every newborn because early detection dramatically influences long-term outcomes. Think of DDH as a spectrum where the ball and socket relationship of the hip joint becomes disrupted in varying degrees. At the mild end, you have simple hip laxity, where the joint feels loose but maintains proper positioning. At the severe end, complete dislocation means the femoral head sits entirely outside the acetabulum. The incidence numbers reveal important patterns for your clinical practice. Hip instability affects approximately 11.5 per 1,000 births, making it common enough that you'll encounter it regularly. However, true dislocation occurs in only 1 to 2 per 1,000 births, representing the severe end that requires immediate intervention. The left hip predominates over the right, with bilateral involvement being less common. The striking 6-to-1 female predominance reflects hormonal influences during fetal development. Understanding these epidemiological patterns helps you recognize that while DDH screening is universal, certain populations deserve particularly careful attention. The risk factors for DDH provide crucial insights into both the underlying pathophysiology and your clinical assessment priorities. Breech positioning stands as the most significant risk factor because it places the hips in sustained flexion and adduction, creating mechanical stress that prevents normal acetabular development. Think of this as months of abnormal positioning that shapes the growing hip joint in ways that compromise stability. Firstborn infants face increased risk due to the tighter primigravida uterus that restricts fetal movement and creates more pronounced positioning effects. The female predominance reflects increased sensitivity to maternal hormones, particularly relaxin, which crosses the placental barrier and affects fetal joint capsule laxity. Family history indicates genetic predisposition, while oligohydramnios removes the protective amniotic fluid cushion that normally allows free fetal movement. Large birth weight compounds the problem by creating additional crowding within the uterine space. These risk factors frequently cluster together, creating cumulative effects. A firstborn female in breech position with oligohydramnios represents extremely high risk and warrants immediate, thorough evaluation. Understanding these patterns helps you allocate your screening attention appropriately while recognizing that DDH can occur in any infant, making systematic examination techniques essential for all newborns. The pathophysiology of DDH involves complex interactions between mechanical forces, hormonal influences, and genetic predisposition that work together to disrupt normal hip joint development. Understanding these mechanisms helps you appreciate why certain risk factors matter and how the condition progresses if left untreated. Mechanical factors center on abnormal in utero positioning that prevents the femoral head from providing proper stimulus for acetabular development. During normal fetal development, the femoral head sits centered within the acetabulum, encouraging the socket to grow deep and stable. When positioning keeps the hip in flexion and adduction, this stimulus disappears, leading to shallow acetabular development that cannot maintain proper joint stability. Hormonal influences involve maternal pregnancy hormones, particularly relaxin, that cross the placental barrier and affect fetal connective tissues. These hormones create increased joint capsule laxity throughout the musculoskeletal system, making the hip more susceptible to positioning effects. The female predominance reflects greater sensitivity to these hormonal influences. Genetic predisposition explains the familial clustering and racial variations observed clinically. These three factors combine to create capsular laxity that allows abnormal femoral head movement within the acetabulum. The critical concept involves understanding DDH as a progressive condition where abnormal mechanics lead to worsening dysplasia over time, making early recognition and intervention essential for preventing permanent joint damage. The physical examination for DDH requires mastering specific techniques that detect different aspects of hip instability, each providing unique information about the joint's condition. Understanding these tests as a systematic approach helps you build confidence in your assessment skills. The Barlow test identifies hips that appear normally located but can be dislocated with gentle manipulation, indicating an unstable but currently positioned joint. The Ortolani test works in reverse, detecting hips that are already dislocated but can be reduced back into position with proper technique. Beyond these dynamic tests, static findings provide additional clues about hip problems. Asymmetric thigh folds suggest unequal leg positioning, while the Galazzi sign shows unequal knee heights when the hips and knees are flexed. Limited hip abduction becomes apparent after 3 months of age when normal newborn flexor tone diminishes. Think of these examination techniques as building a complete picture. The dynamic tests tell you about current stability, while the static findings reveal the consequences of chronic hip displacement. The Barlow test requires precise technique to detect hip instability without causing injury to the developing joint. Begin by positioning the baby supine with the hip flexed to 90 degrees, creating the optimal angle for assessing posterior stability. Your hand placement becomes crucial. Use your thumb on the inner thigh and your fingers supporting the greater trochanter area, providing controlled leverage for the maneuver. The key movement involves applying gentle posterior pressure while simultaneously adducting the hip, essentially trying to push the femoral head out of the acetabulum in a controlled manner. A positive test produces a sensation of the hip dislocating posteriorly, though this should be subtle and easily reversible. The critical teaching point here is that gentleness prevents injury while still allowing detection of instability. Think of this as asking the hip joint a question about its stability rather than forcing it to demonstrate problems. The test indicates an unstable but currently located hip that requires intervention to prevent progression to complete dislocation. The Ortolani test complements the Barlow maneuver by detecting hips that are already dislocated but can be reduced with proper technique. Start with the same positioning, baby supine with the hip flexed to 90 degrees. But the movement pattern works in the opposite direction from the Barlow test. Your hand placement remains similar, but now you'll apply gentle abduction while providing anterior lift with your fingers supporting the greater trochanter. A positive Ortolani test produces a palpable clunk sensation as the dislocated femoral head reduces back into the acetabulum, distinctly different from the soft clicks or pops that many normal hips produce during movement. This difference proves clinically significant. Benign hip clicks represent soft tissue movement or ligament snapping, while the Ortolani clunk indicates actual joint reduction. The positive test tells you that the hip is dislocated but still reducible, representing a more advanced stage of DDH than a positive Barlow test, but still within the range of successful conservative treatment when detected early. Understanding when to use ultrasound versus X-ray for DDH evaluation depends on the developmental stage of the femoral head and what information you need. Before 4 to 6 months of age, the femoral head remains cartilaginous and doesn't show up on X-rays, making ultrasound the preferred imaging modality. Think of this as trying to photograph something that's transparent to X-rays. You need a different technology to see the structures clearly. Ultrasound excels at showing the cartilaginous femoral head, acetabular development, and dynamic hip stability during movement. Use ultrasound for high-risk infants or when your physical examination suggests abnormalities. After 4 to 6 months, the femoral head begins ossifying and becomes visible on X-rays, which then provide better anatomical detail for treatment planning. The controversy around universal screening reflects the balance between early detection benefits and the cost and complexity of screening all newborns. Most programs focus on high-risk populations while maintaining vigilant clinical surveillance for all babies. The fundamental goal of DDH treatment centers on achieving concentric reduction, where the femoral head sits properly centered within the acetabulum, followed by maintaining stability until normal development occurs. Think of this as creating the optimal environment for the hip joint to develop normally. When the femoral head sits correctly positioned, it stimulates normal acetabular growth and depth. The Pavlik harness serves as first-line treatment for babies under 6 months because it maintains the hip in the optimal position of flexion and abduction while allowing some movement for normal development. The success rates reflect the severity of the initial problem. 95% success for unstable hips that can be reduced, compared to 60 to 80% for hips that are already dislocated. This difference makes sense because unstable hips need only stabilization, while dislocated hips require both reduction and stabilization. The harness works by preventing the positions that allow dislocation while promoting the positions that encourage normal hip development. Successful Pavlik harness treatment requires meticulous management and close monitoring to achieve optimal outcomes while avoiding complications. Initial treatment typically involves continuous wear, allowing the hip to gradually adapt to the corrected position. Weekly follow-up appointments become essential during the early treatment phase to assess reduction, monitor for complications, and adjust the harness as the baby grows. The most serious complication involves a vascular necrosis of the femoral head, which can occur if the harness maintains excessive hip flexion that compromises blood supply. This explains why proper harness fitting and regular monitoring prove crucial. You're balancing the need for hip stability against the risk of vascular compromise. When the harness fails to achieve or maintain reduction, more aggressive interventions like closed reduction with casting or open surgical reduction become necessary. The key clinical skill involves recognizing early signs of treatment failure or complications, enabling timely intervention before permanent damage occurs. Understanding the potential long-term complications of DDH helps you appreciate why early detection and proper treatment prove so critical. A vascular necrosis represents the most serious complication, occurring when blood supply to the femoral head becomes compromised either from the original dislocation or from overly aggressive treatment. This complication can lead to femoral head collapse and severe arthritis, making prevention through proper treatment techniques essential. Residual dysplasia occurs when the acetabulum fails to develop normal depth and coverage despite treatment, creating ongoing instability and abnormal joint mechanics. Early osteoarthritis develops because abnormal joint mechanics create increased wear patterns that accelerate cartilage breakdown. Leg length discrepancy results from altered growth patterns in the affected hip, while decreased range of motion reflects joint stiffness from prolonged abnormal positioning. These complications underscore why DDH treatment focuses not just on immediate reduction, but on creating optimal conditions for normal long-term hip development and function. Talipes equinovarus, commonly known as clubfoot, represents a complex three-dimensional foot deformity that you can systematically understand using the acronym CAVE. Each component describes a specific aspect of the abnormal positioning. Cavus creates an abnormally high arch, adductus turns the forefoot inward, varus tilts the heel inward, and equinus points the foot downward like a horse's hoof. These four components work together to create the characteristic appearance of a foot that's positioned down and in compared to normal anatomy. The clinical demographics reveal patterns that influence your approach to evaluation and treatment. Clubfoot affects 1 to 2 per 1,000 live births, making it common enough that you'll encounter it regularly in clinical practice. The 2 to 1 male predominance differs from many other congenital conditions that favor females. Bilateral involvement occurs in approximately 50% of cases, though the severity often differs between feet, making careful examination of both feet essential even when one appears obviously more affected. Understanding clubfoot as a complex three-dimensional problem helps you appreciate why treatment requires systematic correction of each component in a specific sequence. The combination of these deformities creates functional problems that extend beyond cosmetic concerns, affecting weight-bearing mechanics, shoe fitting, and long-term joint health if left untreated. The classification of clubfoot into distinct types provides essential information for predicting treatment complexity and long-term outcomes. This classification system moves beyond simple appearance to help you understand the underlying causes and plan appropriate interventions. Congenital idiopathic clubfoot represents the most common type, occurring in otherwise healthy infants without underlying neuromuscular conditions. Think of this as an isolated developmental abnormality where the foot structures formed normally but became positioned abnormally during fetal development. These feet typically demonstrate good flexibility and respond excellently to conservative treatment approaches like the Ponseti method. Teratologic clubfoot occurs in association with neuromuscular disorders, such as arthrogryposis or myelomeningocele. The key distinction lies in the underlying muscle abnormalities that persist even after foot correction. These feet tend to be more rigid, require surgical intervention more frequently, and carry higher recurrence rates because the underlying neurological problems continue to create muscle imbalances. Positional clubfoot results from intrauterine positioning constraints rather than true structural abnormalities. These feet appear mildly affected and demonstrate excellent flexibility on examination. They typically respond to simple stretching exercises and positioning techniques without requiring formal treatment. The clinical skill involves distinguishing between these types during your initial assessment because the classification fundamentally changes your treatment approach and family counseling about expected outcomes. Understanding the underlying cause helps predict both treatment success and long-term functional results. The clinical features of clubfoot create a distinctive pattern that becomes unmistakable once you understand the underlying anatomical relationships. Each component of the CAVE deformity contributes specific findings that help you assess severity and monitor treatment progress. Forefoot adduction and supination cause the front portion of the foot to turn inward and upward, creating a kidney bean shape when viewed from below. This positioning affects the metatarsals and toes, making them point toward the midline rather than straight ahead. Hindfoot varus and equinus position the heel inward and downward, creating the characteristic appearance where the heel appears to be trying to hide under the leg. The deep medial crease develops along the inner aspect of the foot because the abnormal positioning bunches up the skin and soft tissues. This crease becomes more prominent with growth and serves as a useful landmark for assessing treatment progress. Calf atrophy on the affected side occurs because the abnormal foot position alters normal muscle development and use patterns. The affected calf appears noticeably smaller than the normal side and may remain permanently smaller even after successful treatment. When you step back and observe the overall appearance, the foot looks like it's positioned down and in, with the sole facing backward rather than downward. Understanding these individual components helps you perform systematic examinations, assess treatment progress, and identify residual deformities that might require additional intervention. The clinical examination focuses on determining flexibility versus rigidity, which fundamentally guides your treatment approach and prognosis discussions with families. Recognizing the conditions associated with clubfoot helps you determine when isolated foot treatment suffices versus when comprehensive evaluation becomes necessary. Arthrogryposis presents with multiple joint contractures and muscle weakness, creating rigid clubfoot deformities that require surgical correction. Myelomeningocele causes muscle imbalances due to spinal cord abnormalities, leading to clubfoot that often recurs despite treatment because the underlying neurological problem persists. Chromosomal abnormalities can include clubfoot as part of broader developmental disruptions affecting multiple organ systems. Amniotic band syndrome creates clubfoot through mechanical constriction rather than developmental abnormalities, often accompanied by other band-related deformities. An interesting association involves early amniocentesis, where the procedure timing correlates with increased clubfoot risk, possibly related to amniotic fluid loss during critical developmental periods. The clinical pearl here involves recognizing that isolated, flexible clubfoot in an otherwise normal baby carries an excellent prognosis, while clubfoot associated with neuromuscular conditions often requires more aggressive treatment and carries higher recurrence rates. The Ponseti method has revolutionized clubfoot treatment and represents the gold standard approach worldwide. This technique relies on understanding the specific anatomy of clubfoot deformity and working with the natural flexibility of infant tissues to achieve correction. Think of this as a systematic approach that harnesses the remarkable adaptability of the newborn musculoskeletal system to gradually reshape the foot into normal alignment. The method involves serial manipulation and casting, where each weekly cast holds the foot in a progressively more corrected position. The process typically requires 5 to 7 weekly casts, though some feet need fewer sessions while others require additional correction. The 90% success rate reflects the method's effectiveness when performed correctly and consistently. Understanding this technique becomes essential because it transformed clubfoot from a condition requiring extensive surgery to one managed primarily through conservative treatment. The key insight lies in recognizing that infant bones, joints, and ligaments possess remarkable remodeling capacity when gentle, sustained forces are applied in the correct sequence. The Ponseti method corrects clubfoot through a defined sequence. Cavus is addressed first by aligning the forefoot with the hindfoot and reducing supination. Next, adductus is corrected by abducting the forefoot while stabilizing the talus. Varus is then reduced by further external rotation of the foot. The final correction is equinus, which typically requires a percutaneous Achilles tenotomy to achieve adequate dorsiflexion. The post-correction protocol proves just as critical as the initial casting sequence because maintaining the achieved correction requires ongoing intervention. Achilles tenotomy becomes necessary in 80 to 90% of cases because the equinus component rarely corrects completely through casting alone. This simple office procedure involves percutaneous division of the Achilles tendon, allowing the foot to achieve proper dorsiflexion positioning. Following tenotomy and final cast removal, the foot abduction brace becomes essential for maintaining correction. This device, consisting of boots connected by a bar, holds both feet in external rotation and dorsiflexion. The protocol requires 23 hours daily wear for 3 months, followed by nighttime and nap wear until age 4 to 5 years. Family compliance during this bracing phase determines long-term success because the foot will gradually return to its original clubfoot position without consistent bracing. The extended timeline reflects the time needed for ligaments, joint capsules, and muscle balance to adapt permanently to the corrected position. Metatarsus adductus represents the most common congenital foot deformity, characterized by medial deviation of the forefoot while the hindfoot remains in normal position. To visualize this condition, imagine the foot as having 2 segments. The back half stays normal while the front half curves inward, creating what we call a bean-shaped sole when you look at the bottom of the foot. Understanding the distinction between flexible and rigid types becomes crucial for your clinical approach. Flexible metatarsus adductus allows you to manually straighten the foot with gentle pressure, while rigid forms resist correction despite your efforts. This flexibility assessment determines both treatment needs and prognosis. The reassuring aspect of this condition lies in its natural history. Most cases resolve spontaneously as the child begins walking and the foot experiences normal weight-bearing forces. Think of this as a positional problem that typically corrects itself through normal development and activity, unlike structural deformities that require active intervention. Your evaluation of metatarsus adductus centers on 2 key assessments that guide treatment decisions. The heel bisector test provides objective measurement of the deformity severity. Draw an imaginary line through the center of the heel extending forward. In normal feet, this line passes between the 2nd and 3rd toes, while in metatarsus adductus, it passes lateral to the 3rd toe or even beyond the 4th toe, depending on severity. The flexibility assessment requires gentle manual pressure to determine whether the forefoot can be brought into neutral or overcorrected position. This distinction between flexible and rigid forms proves clinically essential because it determines treatment approach. Always screen for hip dysplasia, as these conditions associate in approximately 10% of cases. The key differentiation from clubfoot lies in the hindfoot position. Metatarsus adductus maintains normal heel alignment while clubfoot involves both forefoot and hindfoot abnormalities. Document the severity and flexibility findings because these factors predict which babies need intervention versus observation. Management of metatarsus adductus depends entirely on the flexibility and severity you identified during your evaluation. Flexible types respond well to observation combined with gentle stretching exercises that parents can perform during diaper changes. Think of these stretches as encouraging the foot's natural tendency toward correction rather than forcing change against resistant tissues. Rigid forms require more aggressive intervention, particularly when the deformity is severe enough to interfere with normal shoe fitting or walking development. Serial casting becomes the treatment of choice for these cases, with cast changes every 1 to 2 weeks as the foot gradually assumes better alignment. The casting works similarly to the Ponseti method for clubfoot, applying gentle, sustained forces that encourage tissue remodeling. Surgery is rarely needed because even rigid forms usually respond to conservative treatment when managed appropriately. The excellent prognosis reflects the condition's fundamental nature as a positional deformity rather than a structural abnormality, making successful outcomes the expected result with proper management. Calcaneovalgus foot presents as the complete opposite of clubfoot positioning, where the foot becomes so dorsiflexed that it can actually touch the anterior tibia. Picture a baby whose foot is bent upwards so severely that the top of the foot nearly touches the shin. This dramatic positioning creates the characteristic appearance that makes the diagnosis obvious on visual inspection. This condition typically results from intrauterine positioning rather than structural abnormalities. Think of it as the fetal equivalent of keeping your foot pulled up toward your shin for months, causing the tissues to adapt to this extreme position. The increased occurrence in firstborns reflects the tighter uterine environment that creates more significant positioning constraints. Unlike clubfoot, which involves complex structural relationships, calcaneovalgus foot represents a pure positioning problem where normal anatomy has been held in an abnormal position for an extended period. Understanding this distinction helps you counsel families about the excellent prognosis and the likelihood of spontaneous resolution with normal development. The clinical presentation of calcaneovalgus foot creates a distinctive pattern that contrasts sharply with other foot deformities. Excessive dorsiflexion allows the foot to bend upward beyond normal range, while limited plantar flexion prevents the foot from pointing downward into normal positioning. This combination creates the characteristic appearance where the foot seems stuck in an upward position. Lateral foot deviation accompanies the dorsiflexion, creating a foot that points both upward and outward. The crucial clinical insight lies in recognizing that this involves soft tissue contracture only, without any underlying bony abnormalities. The muscles, tendons, and joint capsules have simply adapted to the prolonged intrauterine positioning, creating tightness that maintains the abnormal position. This soft tissue nature explains why the condition responds so well to conservative treatment. You're working with normal bones and joints that just need the surrounding soft tissues to relax and stretch back to normal length. The absence of structural abnormalities makes this fundamentally different from conditions requiring surgical correction. Management of calcaneovalgus foot emphasizes the power of conservative treatment for positioning-related deformities. Gentle stretching exercises performed by parents during routine care help encourage the contracted tissues to gradually return to normal length. These stretches work by applying sustained, gentle forces that promote tissue remodeling without causing pain or injury to the baby. The timeline for spontaneous resolution typically ranges from 3 to 6 months, reflecting the natural healing capacity of infant tissues when positioning constraints are removed. Casting becomes necessary only in severe cases where the deformity resists simple stretching or interferes with normal development. Always screen for hip dysplasia because the same intrauterine positioning factors that cause calcaneovalgus foot increase the risk of developmental dysplasia of the hip. The excellent prognosis reflects the condition's nature as a reversible positioning problem rather than a permanent structural abnormality. Parents need reassurance that this dramatic appearing deformity will resolve with time and simple interventions, avoiding unnecessary anxiety about long-term disability. Congenital vertical talus creates a rocker bottom foot deformity that represents one of the most serious congenital foot abnormalities you'll encounter. Unlike the positioning problems we've discussed, this condition involves actual structural abnormalities where the talus bone becomes vertically oriented instead of maintaining its normal horizontal position. This creates a rigid flat foot with a convex sole that rocks like the bottom of a rocking chair when placed on a flat surface. The clinical significance extends far beyond the obvious foot deformity because this condition frequently associates with syndromic conditions affecting multiple organ systems. Think of congenital vertical talus as a red flag that should prompt comprehensive evaluation for associated anomalies. The structural nature of the abnormality means that conservative treatments like stretching or casting typically fail, requiring surgical intervention to restore normal foot mechanics. The combination of structural complexity, syndromic associations, and need for surgical correction makes this condition fundamentally different from the positioning-related foot problems that respond well to conservative management. The clinical features of congenital vertical talus create a distinctive pattern that reflects the underlying anatomical disruption. The defining characteristic involves fixed dorsal dislocation of the navicular bone, where this midfoot bone sits permanently displaced on top of the talus instead of maintaining its normal articulation. Think of this as the foot's architecture collapsing because a key structural component has moved out of position. This dislocation creates rigid equinus positioning of the hindfoot, where the heel remains pointed downward and cannot be brought into normal alignment. The rigidity proves diagnostically significant because you cannot correct the deformity passively, unlike positioning problems that yield to gentle manipulation. The abnormal bone relationships create a deep crease across the dorsal foot where the skin bunches up due to the structural collapse. The overall appearance resembles a Persian slipper with its characteristic curved, upward-pointing shape. Understanding these features helps you distinguish vertical talus from other foot deformities and recognize why this condition requires surgical intervention rather than conservative management. The syndromic associations with congenital vertical talus underscore why this finding should trigger comprehensive evaluation rather than isolated foot treatment. Chromosomal abnormalities frequently include vertical talus as part of broader developmental disruptions affecting multiple organ systems. Myelomeningocele creates vertical talus through altered muscle balance and neurological control, while arthrogryposis produces the deformity through generalized joint contractures and muscle weakness. Various neuromuscular disorders can manifest vertical talus as one component of their clinical presentation, reflecting the complex interplay between normal muscle function and foot development. The isolated form remains quite rare, meaning that when you encounter this deformity, you should assume syndromic involvement until proven otherwise. This pattern recognition becomes clinically crucial because it changes your entire approach from isolated orthopedic care to comprehensive multidisciplinary management. The baby with vertical talus likely needs genetic evaluation, neurological assessment, and screening for associated anomalies in multiple organ systems, making early recognition and appropriate referral essential for optimal outcomes. Treatment of congenital vertical talus has evolved to incorporate principles from the successful Ponseti method, adapted for this more complex deformity. The reverse Ponseti method uses serial casting to gradually stretch the dorsal structures that maintain the abnormal positioning, working systematically to restore more normal anatomical relationships. This approach represents a significant advance over historical treatments that relied primarily on extensive surgical reconstruction. However, the structural nature of vertical talus means that serial casting alone rarely achieves complete correction, and surgical reduction often becomes necessary to restore proper bone alignment and joint function. The timing of intervention proves critical because delayed treatment allows the abnormal mechanics to become more firmly established, making correction increasingly difficult. Unlike the positioning problems that respond beautifully to conservative treatment, vertical talus carries a guarded functional prognosis even with optimal management. The combination of structural complexity, frequent syndromic associations, and need for surgical intervention makes this condition fundamentally different from other foot deformities, requiring specialized care and realistic expectations about long-term outcomes. Tibial bowing represents one of those clinical situations where accurate classification fundamentally changes your approach because each type carries completely different implications for the baby and family. Understanding these distinctions helps you move beyond simply describing what you see to predicting what will happen and planning appropriate care. Posteromedial bowing stands as the most common type and fortunately carries a benign prognosis with spontaneous improvement expected over time. Anterolateral bowing presents an entirely different clinical picture, strongly associating with neurofibromatosis type 1 and carrying significant risk for fracture and pseudarthrosis development. Think of this as the high-risk variant that demands immediate protective measures and long-term surveillance. Anteromedial bowing typically occurs with fibular hemimelia, representing part of a broader limb deficiency syndrome. The key clinical insight involves recognizing that these aren't just different directions of the same problem. They represent distinct conditions with different causes, associations, and outcomes requiring tailored management approaches. Posteromedial tibial bowing represents the reassuring end of the tibial bowing spectrum, characterized by its benign nature and predictable course towards spontaneous improvement. This condition commonly associates with Calcaneovalgus foot, reflecting shared intrauterine positioning factors that create both deformities simultaneously. Think of these as companion problems that result from the same mechanical forces during fetal development. The clinical counseling point centers on the expected 3 to 5 centimeter leg length discrepancy that typically develops, though this sounds more concerning than it actually proves to be functionally. The angular deformity shows spontaneous improvement as the child begins walking, and normal weight-bearing forces encourage bone remodeling toward normal alignment. No treatment is needed during infancy because the natural developmental process works more effectively than any intervention we might provide. Understanding this natural history helps you reassure families about the excellent prognosis while preparing them for the leg length difference that may require future monitoring but rarely needs active treatment. Anterolateral tibial bowing demands immediate recognition because it represents a completely different clinical entity with serious implications for the child's future. The strong association with neurofibromatosis type 1 means that every baby with this bowing pattern needs comprehensive evaluation for café au lait spots, neurofibromas, and other manifestations of this genetic condition. Think of the tibial bowing as an early warning sign of broader systemic involvement. The high risk of fracture and pseudarthrosis development creates the most concerning aspect of this condition. Unlike posteromedial bowing that improves spontaneously, anterolateral bowing often progresses to fracture through the apex of the deformity, followed by failure of normal bone healing that creates a persistent non-union. This explains why protective bracing becomes essential from early infancy, even before fracture occurs. The poor prognosis following fracture reflects the difficulty of achieving union in these cases, often requiring multiple procedures and sometimes resulting in amputation. Long-term orthopedic follow-up becomes mandatory because the risk persists throughout childhood growth. Congenital knee dislocation represents one of the rarest lower extremity abnormalities you'll encounter, occurring in only 0.017 per thousand births, but its clinical significance extends far beyond its rarity. To understand this condition, imagine the knee locked in complete hyperextension where the baby cannot flex the joint at all. This creates a leg that appears straight as a board, completely unable to bend at the knee joint. The underlying problem involves quadriceps contracture, where the thigh muscles have become shortened and fibrotic, preventing normal knee flexion. This contracture develops during fetal life, creating the characteristic presentation of a hyperextended knee that feels rigid to manipulation. The clinical importance lies in the associated conditions. Developmental dysplasia of the hip occurs in 70 to 100% of cases, making hip screening absolutely essential. The condition can also present as part of arthrogryposis, where multiple joint contractures affect the entire body. Understanding these associations helps you recognize that congenital knee dislocation rarely occurs in isolation, requiring comprehensive evaluation of the entire musculoskeletal system. Management of congenital knee dislocation requires immediate intervention because delayed treatment leads to progressive stiffening that becomes increasingly difficult to correct. The principle behind treatment involves serial casting in progressive flexion, similar to the approach used for clubfoot but working in the opposite direction. Think of this as gradually teaching the contracted quadriceps muscle to lengthen while encouraging the knee joint to remember how to flex. Start treatment immediately after birth because infant tissues possess remarkable remodeling capacity that diminishes with age. The casting process requires gentle manipulation to avoid injury to the growth plates and surrounding structures, followed by casting that maintains the achieved flexion while allowing gradual improvement. When casting fails to achieve adequate flexion, surgical release of the contracted quadriceps becomes necessary. The critical reminder involves checking the hips carefully, because the high association with developmental dysplasia of the hip means that successful knee treatment becomes meaningless if you miss coexisting hip problems that require their own intervention. Proximal femoral focal deficiency encompasses a spectrum of femoral abnormalities that range from mild shortening to complete absence of the femur, creating some of the most challenging lower extremity reconstruction problems in pediatric orthopedics. To grasp the complexity, think of this condition as affecting the foundation of the entire lower extremity. When the thigh bone is abnormal, everything below it must compensate for the altered mechanics and length. The spectrum nature means that each case presents unique challenges, from subtle shortening that might be managed with lengthening procedures to complete femoral absence requiring prosthetic fitting. The condition often associates with fibular hemimelia, creating complex combined deficiencies that affect both the thigh and lower legs simultaneously. The resulting limb length discrepancy can be dramatic, sometimes involving differences of 10 centimeters or more. These cases require complex reconstruction planning that might involve multiple lengthening procedures, joint reconstructions, or amputation with prosthetic fitting. The decision-making process must balance functional outcomes against the complexity and risk of multiple procedures, making early subspecialty consultation essential for optimal treatment planning. Lower extremity. Polydactyly follows patterns similar to hand polydactyly, but carries different functional implications that influence your clinical approach. Postaxial polydactyly affecting the fifth toe represents the most common presentation, creating an extra digit on the outside border of the foot. This location matters because it affects shoe fitting more than function, unlike thumb polydactyly, which significantly impacts hand mechanics. The demographic patterns mirror those seen in upper extremity polydactyly, with higher incidence in African Americans, where it typically appears as an isolated finding with excellent prognosis. The same Type A and Type B classification system applies here. Type A represents well-formed digits with proper bone structure and joints, while Type B appears as rudimentary skin tags or nubbins without significant skeletal development. Bilateral involvement occurs frequently, making examination of both feet essential, even when one side appears normal. The clinical significance lies in understanding that foot polydactyly rarely causes functional problems, but can create practical issues with shoe fitting and cosmetic concerns. Unlike finger polydactyly, where function drives treatment decisions, foot polydactyly management focuses primarily on enabling normal shoe wear and addressing family concerns about appearance. The reduced functional impact means that treatment timing becomes more flexible, though the same principles of preserving the most normal digit apply when surgical intervention becomes necessary. Management of toe polydactyly follows the same type-based approach used for finger polydactyly, but the reduced functional demands of the foot allow for more flexible treatment timing. Rudimentary Type B digits can be managed with simple suture ligation in the nursery, similar to the approach used for finger polydactyly. This technique works well for pedunculated lesions that lack significant bone or joint involvement. Articulated Type A digits require formal surgical removal, typically performed between 9 and 12 months of age, when the baby can better tolerate anesthesia and the anatomy becomes more clearly defined. The surgical decision-making process involves identifying which digit demonstrates the best bone structure, joint alignment, and overall anatomy, then removing the less functional extra digit while preserving the most normal one. Shoe fitting considerations become paramount in treatment planning because the primary functional issue involves accommodating the foot within standard footwear. This practical concern often drives treatment timing more than pure medical necessity. The reduced functional impact compared to finger polydactyly means that families and surgeons can approach the timing decision with less urgency while still achieving excellent outcomes. When syndromic associations are suspected based on the pattern of involvement or associated findings, genetic counseling becomes essential to help families understand recurrence risks and the need for comprehensive evaluation of other organ systems. Several fundamental concepts from lower extremity anomalies deserve emphasis because they directly impact your clinical decision-making and patient outcomes. Developmental dysplasia of the hip stands as the most critical condition requiring universal newborn screening because early detection and treatment prevent lifelong disability, while delayed diagnosis leads to complex reconstruction needs and permanent functional limitations. Clubfoot management has been revolutionized by the Ponseti method, which transformed this condition from one requiring extensive surgery to one managed primarily through conservative treatment with excellent functional outcomes. Understanding this method as the gold standard helps you counsel families appropriately and ensures timely referral for optimal results. Calcaneovalgus foot represents the benign end of the spectrum, where dramatic appearance resolves spontaneously through normal development and simple interventions. This knowledge helps you provide reassurance while avoiding unnecessary aggressive treatment. Conversely, congenital vertical talus presents as a rigid deformity requiring aggressive treatment because conservative approaches fail to address the underlying structural abnormalities. The unifying clinical principle involves recognizing that many lower extremity conditions associate with developmental dysplasia of the hip, making hip examination essential whenever you encounter foot deformities. This association reflects shared developmental mechanisms and risk factors, emphasizing the importance of comprehensive evaluation rather than isolated treatment of obvious abnormalities.